Hey folks, Doug Blake with Body Design University. Welcome to another weekly study. And today we're going to talk about lordosis and kyphosis. But really, we're going to talk about the fact that perhaps we found a little typo in the 7th edition. It happens, and it gives us an opportunity to talk about a couple of things that are really important, not about a typo in the textbook, but more importantly about what this relates to just in general, and helps us to understand a couple of things about the materials. So I think it was Mishka that posted this, and good job, by the way, finding this, because you're generally not going to be too worried about the issues or the terminology that we're using here per se. And I'm going to show you what's important about this part of it. But it did trip her up, and she probably was thinking to herself, wait a minute, I've seen this before, or maybe I was looking at something, or I was reading something, maybe doing some outside research, which is more than likely what I think Mishka was probably doing, which is great. There's absolutely nothing wrong with that. And when you find something, yeah, sure, you let us know, and we're more than happy to send that along to the NASM folks. And they probably already know it anyway, to be honest with you. It was on page 520, and it was just two little words that got switched. And quite honestly, the words are, in one sense, not really as relevant as the concepts themselves, which are obviously correct. So let me go ahead and pull us up here and get us going. So lordosis and kyphosis. Again, the fact that there's a little typo actually gives us an opportunity to talk about a really important subject matter, which are the curvatures of the spine. And so lordosis and kyphosis, by convention, this is a key. Remember, I said there's a couple of things that are important here. One of them is to understand that in the field of anatomy and physiology, biomechanics, kinesiology, we have what's known as conventions. So conventions mean that we always start in this position. So for instance, anatomical position. The conventional stance for anatomical position is a certain way, right? So when we talk about flexion, extension, abduction, adduction, we use this term anatomical position to help us to express what those terms mean. And so by convention, we use this, this, and this. And then that's what we do with lordosis and kyphosis. By convention, we use lordosis and kyphosis to speak to the actual curves or shapes of the spinal column when viewed from the side, or lateral view. Remember, from the front, if you look at me from the front right here, without not my body, other than my spine should be completely straight up and down. Okay, it's not. I'll be honest with you. I got a little bit of scoliosis down in my pelvic region, but ideally it should be straight up and down, viewed from the front and from the back. Scoliosis is a lateral deviation of the spinal column anywhere along the spinal column. That's not normal. However, the lordotic and kyphotic curves that we see in the spinal column from a lateral perspective are normal curves. So again, Mishka, thank you for bringing up the fact that there was a typo. It gives us an opportunity to talk about some of the important things about these curves in relation to the materials in the textbook. And by the way, this is chapter, I said page 520. So that's chapter 16, and optimizing posture. So again, it's very important to know this about, especially from an assessment perspective, and then understanding the overactive, underactive muscle scenario that people seem to struggle with. By the way, there is a real world component to this that you do not want to negate. And because we're talking about the pelvic region, and that's again on page 521, don't negate this stuff. It's really good information that you'll want to take with you after you pass your exam and start working with clients in the real world. That whole pelvic tilting stuff at the LPHC, lumbopelvic hip complex, really, really important. And NASM nails it. They do a great job with this. So lordosis and kyphosis. So what was the problem here? Well, and all I did was I just cut and pasted this one part at the very top of page 520, optimizing posture. Says that the human spine demonstrates naturally occurring curvatures that alternate between lordotic. And here is where the problem occurred. You know, don't want to beat it up too bad. There's the word and there's the word. They just should have been switched. That's all. Just so you guys understand that lordosis, the lordotic curve is concave. That's not the issue. The issue is that concavity means that there is inward curve. So concavity, I'm going to show you that in a second. Concavity is inward curves, convexity or outward curves. Mishka actually figured this out when she Googled it and she got a picture, and I'm going to show you to you. But here's the key to remember. Don't focus on that so much. Here's what I want you to focus on. Lordosis is concavity, right? Concave curves. Okay, that's lordosis. And that's what you need to remember as you're going through this material. Kyphosis is convex. So that's what I want you to focus on from a memorization perspective. Concavity and convexity. Concavity is, think of an hourglass, right? That's concave, right? A cave, right? Whoop, inward, caving in. And then convexity is when the center part of a lens, for instance, is bulging at the center. And so those bulges are outward. And that is the only real issue, are those terms. Otherwise, everything is perfect. And again, all I did was cut it off. It wasn't necessary to go through the rest of it. But just keep in mind, as you're going through this, when you're looking through this material, lordosis equals concavity and kyphosis equals convexity. And I'm going to throw you off a little bit, even at the end as we go through here. This is what Mishka pulled up. Thankfully, she went out and said, wait a minute, this doesn't make any sense. Concavity is inward. Convexity is outward. And she was correct. By the way, just keep in mind that normally we talk about lenses, and that's why we have these pictures. But keep in mind also that concavity, and let me get rid of this. We don't need this anymore. I'm going to go ahead and erase all ink on the slide. And keep in mind, there's a curve here, there's a curve here, it's a curve on that side, and a curve on that side. They're both outward, okay? And in this case, they're both inward. So just keep that in mind, that when you're looking at a lens, for instance, and that's really what this is talking about, in a regular lens that you look at, the middle is thicker for convex, middle is thinner than concavity. And again, that's where the confusion came in. So Mishka is not going insane. Concavity is inward, and that just should have been, that's all. It's just a, just a little issue right there. Here is the thing to keep in mind. We are talking about a lens. That's why these pictures, okay, are important to look at. Gives you an understanding that either way you look at it, convexity is bulging out, so outward, and concavity is bulging in. So how does this relate to the human spinal column? Here's where I'm going to confuse you a little bit. Well, maybe not confuse you, but I want you to understand something. That, remember what I said, we look at, or we talk about the spinal curves, and by convention, now remember, we look at it either posterior or anteriorly. And that's why I wanted to show you this. The spinal curves, and there's 4 of them, okay? There is a cervical curve, and that is called a lordotic curve. Now close your eyes for a second, and what does lordosis mean? Right, concavity, right? Concave curve. There is what's known as a thoracic curve, and it's a kyphotic curve. That's number 2. And what is kyphosis? Convexity, right? Then there is a lumbar curve. okay, and that's going to be similar to the cervical. It is lordotic. And then, of course, at the very bottom of your spine, you have what's known as the sacral or sacrum coccyx complex, and at your tailbone. So that, again, is kyphotic, okay? However, take a look at what we have here. Here's your spinal curves, kyphosis and kyphotic curve. Now, keep in mind, by convention, we have to choose one or the other, because remember, if I were to look at the kyphotic curve from the front to the back, now remember, this person right here, let me see if I can draw you a face. I'm going to draw you a little face. So this person, right, is looking, they're looking to the front this way. So this is the front part of the body, right? Front's over here, posterior is over here. So this individual is facing, well, let me see if I can do this for you, right? They're facing this way as you see this video, okay? So they're facing this way for you, okay? Now, if I look at it from the posterior to the anterior, that's what this line, this arrow represents. A kyphotic curve is convex. However, if I look at it from the other way, it's concave. And that's all this is saying, right? I said I was going to confuse you a little bit. I hope that's not confusing. So what do we choose then? Well, obviously, by convention, we use the terms to describe posterior to anterior view. I hope that makes sense. So posterior to anterior view of the cervical spine shows what? Concavity, right? And that's what we're saying here. Concave posteriorly, convex anteriorly. Okay. Because look, if I look at it from the front to the back, what kind of curve is that? Well, it's a convex curve, right? It's outward, a bulging outward curve. Hope that makes sense. So by convention, we say from the back, okay, this is a mess, so let me get rid of this. Let's try this again. So what we do by convention, remember what I said? By convention, we don't just get to say that the lordotic curve in the cervical spine is, the cervical spinal curve is kyphotic. You don't say that because it's not. It's by convention, it's lordotic or concave. Why? Because the curve laterally, if seen from or if expressed from the posterior to the anterior, is this way. And that's going to look like an hourglass, right? So remember what we said about concavity, right? So because by convention, we look at it from the posterior looking forward. Well, in this case, it's looking like that. Therefore, a kyphotic curve, right, is what? It's going to be outward convexity. But remember, if I look at it from the front looking backward, well, that is what? That's an inward curve, right? You would say that's an hourglass, like that. I hope that makes sense. That's why we don't get to choose which one no, by convention, we always look from the rear this way, okay, not the other way around. Therefore, in conclusion, this is a lordotic or inward curve. This is a kyphotic. Remember, that's the thoracic. Those 12 guys right there, thoracic vertebrae is a kyphotic or outward curve. And then, of course, the lumbar down in the lumbar area is a lordotic or inward curve. And of course, tailbone, coccyx area right there. Why? Let me ask you this. Why is this important? Let me get rid of all this. Why is all that important, by the way? All right, just don't worry about the inward outward right typo. Let's stay focused with me now, because it's important to understand lordosis and kyphosis. Why is that important? What is it about these curves in the spinal column that are so critical? And the answer is this: it's mobility. It's mobility of the entire trunk, LPHC, trunk, abdominal, thoracic region, and of course the neck and the head. Each individual spinal segment does not have a whole lot of mobility to it. Okay, very little lateral mobility, right? That's why scoliosis is not a normal curve. It's an abnormal curve. Distortion, deformation of the spinal column. But these guys, the S, what we term the S curve, the little thing down there, actually allows for high levels of mobility forward and backward. Now, from that perspective, I hope you can understand as you move along to page 521, 522, and onward in this particular area. The whole, and by the way, it's not just this area. It's when you're actually talking. I forgot what chapter that they really get into it. But here they're reiterating one of the most critical components of exercise itself when it comes to actually training clients, which is the LPHC. Don't get me wrong, the shoulder girdle, the shoulder is important, but where we see the most problems with the average client, people that sit down all day, is going to occur right in this area. So we're going to see increased curvature or increased lordosis, right? Which of course could have, caused problems with the thoracic spine, where you get increased kyphosis. So the normal curves, the normal lordotic and the normal kyphotic curves can actually be increased, overemphasized, because of the way the muscles that are overactive are pulling on those particular areas of the skeletal system, and therefore the underactive muscles are allowing that to occur. So you can see, if you look at some of the visuals that they have, some of the figures that they have here, it starts to make more sense that when you think of the curves, you're simply increasing the actual normalcy of the lordotic curve here, which leads to actual pathologies or problems with that area. Increasing the kyphotic curve, or what's termed kyphosis, leads to many problems as time goes on. And our goal ultimately, right, from lordosis and kyphosis, now we can actually talk about sort of a corrective level of training and helping people to stretch and strengthen. Remember, overactive and underactive muscles, when you take that into the real world, it's two things: stretching the overactive and strengthening the underactive. Now, you know that there's a whole nother bag of worms that we can open up when it comes to memorizing the actual muscles. But look, the reason I wanted to explain this and go over it with you was for a number of reasons. Okay, there's a typo. You caught it. That's really good. You asked the question, bring it into the group itself, bring it out there. Let's go ahead and do an actual study on it. The more of these that we see, the better it's going to be for all you guys in the Facebook group itself. The other thing to remember is that these are normal curves. The other thing on top of that is that by convention, just like other components that we see in anatomy, phys, and kinesiology, by convention, we use specific terminology. Let me give you an example, by the way. I was just thinking about it. And if you've gotten to it, the terms agonists and antagonists muscles. Now, in kinesiology, we have standard terminology, such as flexion and extension. And I've seen it 100 times if I've seen it once, or I've heard it 100 times if I've heard it once. The confusion that a student will have with respect to whether a muscle is an agonist or an antagonist. Now, let me just stop for a second. How many of you kind of have that issue, right? Have you seen some questions in the quizzes or on the practice exams that speak to whether or not the bicep is the agonist or the tricep is the agonist in a particular movement? Keep in mind, and I'll use that as an example, your elbow flexes and extends, right? Flexion and extension are kinesiological terms that describe the skeletal system movement. However, agonist and antagonist describe the musculature around the particular joint and which one is active as a prime mover. So what does this have to do with lordosis and kyphosis? Absolutely nothing other than the fact that we're talking about convention, right? By convention, we say that the agonist during a dumbbell curl, for instance, the agonist is the biceps, and therefore the tricep is the antagonist. However, the same kinesiological terminology is used when we do a push down where the tricep is the agonist and the bicep is the antagonist. So again, if you're confused by the conventional terms and some of the other concepts that I literally just spoke about, go ahead and let me know. Message at the bottom, and we'll do a study on that. So the idea, ladies and gentlemen, let me get out of this, is to answer a couple of issues that Mishka actually brought up by making note of those terms being switched. And that's really all it is. So if you have other questions on this chapter, this area, or any other, that's what we're here for. So go ahead and post it. Let us know how we can help. Remember, the goal ultimately is to have you guys get through the materials, however you need to do it, whatever your study techniques are that help you, is to help you to pass the NASM exam on the first attempt. If you have already taken it and you fail, then the goal is obviously to get you to pass on your second attempt. Keep in mind, we are here to help you out as best we can. Post your questions, let us know, even message me directly if you need to. Let us know how we can help and answer any questions that you may have. Best of luck, and we'll see you next week. Thanks.